Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Sonya Bruton, CEO and President of CCI Health Services, about relationships and community, the fabric of rural health. Let's get started. Dr. Dan, it is good to see you again.
It's good seeing you, Faisel.
We just came back from a camping trip late last night from Mount Rushmore, so I feel completely recharged, re-energized. I've got, been able to just ponder about all the things that really matter. And at the end of it, it doesn't matter if it's with our patients, with each other as colleagues, with our family, with our children. At the crux of it all comes down to relationships. And so with having Dr. Bruton here, I wanted to ask you about the work that you're doing with keeping the doctor-patient relationship, the doctor-team relationship, the doctor-doctor relationship at your community health center sacred.
I have to start with what you first triggered, and that's just kind of taking that time to be alone, be out in nature. I'm an Outward Bound graduate. And I did in my late teens, their 3-week, they call it they have a different name for it now, but it's their basically marquee 3-week program. And right before the end, a week before the end, so that you can really get the benefit of the experience, process it before you go back into the world, we do a solo. And when you were talking about that Mount Rushmore, the impact of it, that rejuvenation, that recentering, that perspective taking, it reminded me of that, and is actually a perfect lead in to the response to the question. And it is a combination of filling yourself, keeping yourself full, keeping yourself grounded, being centered, and being able to take different perspectives that then allows for you to then generate, maintain, support, and feed connected teams.
There's so much in the community health space that we see. I mean, I started my career in community health, and I ended up working in underserved populations in Medicare Advantage and now in Medicaid. And, oftentimes in our day-to-day interactions with the teams and with the patients, like there's one story being told by those interactions, and then like the data and a lot of the policy stuff, it's like there's another story, and then we're like, how do you help your teams navigate through that? I mean, it's like the world is seeing one thing, but we're seeing another.
Absolutely. It's a concept that happens for all of us, and I'm sure we can all relate to, and that is putting out a level of effort and then not getting credit for all of it. And that starts young in the home and continues and can continue even at work. But we find that all the time where, we have lived experience that tell us all the things that we have done for a patient, all the things that we have improved for the patient, and then numeric data that doesn't match up, that doesn't acknowledge or even represent and give credit for everything that was done. And so the first thing that we have to do is deal with the discrepancy and not let that begin to discredit the effort on both sides, because you'll have the person who says, but I know my patients are getting better, and I see, Ms. Johnson and all that she can do now. And then usually for us, it's a insurance payer or regulator that's looking at it and saying, but it doesn't look like you are making the improvements that we expect or that you led us to believe were happening. And so the first thing is to acknowledge the gap and then begin to disassociate the gap from effort. So it's a system problem, it's a numeric issue. For us, unfortunately, it is the beauty of computers and the curse of computers, because what will often be the case for us is that the information just doesn't live in a pullable format. It's not an OBS term. It's not something that the computer can easily find and grab, because if it lives in something like an attached document or in a paragraph that needed to have been split up to 5 different fields, then the system won't recognize it. And so it's for us, that becomes then we're able to show the person putting forth the effort. We see you, we know, and we still have more support to give on the other side to make sure that all of your efforts can be fully received. And so for us, that means reconfiguring systems, putting together forms, added work, work that I'm sure you're recognizing as you're listening to it takes away from other efforts, but you got to feed that beast that says you have to prove your worth in medicine more and more. And as we talk about HEDIS metrics and star ratings and value-based care, pay for performance, it's going to boil down to what can be pulled by a machine and offered up as evidence. And so we are forced to keep putting the time into closing the gap. But it's time, it's money, and right now, as a system in the community health center world, we're lagging behind, and we know it.
Right. And it's interesting that you bring that up. I think of it as the difference between accountability and responsibility. I mean, I like the word responsibility because that means you've got the ability to respond. So that doesn't mean accountability sounds like you're counting something and you're holding people accountable. But if you're asking them to take responsibility, you're asking them to respond in a way that would improve care to the patient. Even, let's just assume the data is correct. We don't have, it may be or it may not, but what could you do with the data that would make a difference for your patients? And we're not blaming you for it. We're just asking you to do what you come to work to do naturally every day anyway.
Yeah, it kind of reminds me of what you said when you were on the panel in DC at the Primary Care for America, and you said that there's a distinction of viewing community health centers as clinics versus viewing them, if I remember, like as the fabric of the community. And I wish I would have had that mindset earlier on in my career, especially when I was in residency. I definitely felt it, but I didn't have that as a mindset. Most of our listeners they're people who are geeky about primary care residents, a lot of students. But for someone who's early on in their career, like what would you advise them to help them have that mindset shift earlier on, where they can view this work like, hey, you're a part of the community, you're a pillar of the community?
Absolutely. The first thing that I always do, especially when I'm talking to people who are engaged in primary care because they want to be primary care practitioners, the start of the conversation really for us is, what do you want out of medicine? That's the first question, because I find that that's more defining than anything else. And sometimes what we're able to identify right off the bat is, we're never going to be able to give you that. That can't be found here. Sometimes it can't be found in medicine. Sometimes it starts to unearth some notions, some fantasies, some guesses from looking from the outside in, that just medicine won't ever give you that. Like, you got to get that from other places. It won't come from medicine. So I first try to find out what's the baseline of just the motivation or the draw, period, kind of broadly. And then to get that mindset to shift to be more of a collaborative venture, which is what community kind of represents. Community is about bringing together different perspectives, different stages, and to recognize that that's really how you treat a person. Medicine is a discipline that can be learned and has facts that are never constant, that we're always learning more, learning new, adding on, shifting around. So I also try to make that really clear. Like, if you need the same or status or staticness or sureness, medicine's not going to give you that, because what is evidence-based or the best way or efficacious today will tweak in some way 10 years from now. And for those of us in this work, we're in it for decades. And there are those for whom that jazzes them, and that's great. But there are those for whom that's vexing. And we see that in the workforce, and you have people holding on to the way they did it or the way they learned it or what they knew back then. And it's so hard to get them to shift sometimes. And you get others where they're looking for the shift, can't wait for the shift. But so I first start with, what are your expectations? And then the collaborativeness, the coming together of community, and to recognize that actually that is where you find, that's the sweet spot of the best medicine, the best experience, and where true satisfaction is going to come in. Because even if the patient you're working with, or the community member, or the project, or the group, even it doesn't matter what, even if what they come with doesn't change your knowledge, and so it won't change the treatment, it'll change their adherence to it. It'll change their understanding of it. Because when you're letting them bring what they know about themselves, what they know and can share about their situation, when you then bring them what is going on and what can be done about it, there's still the power of those two things coming together in a way that actually creates change. What I find is that sometimes you also get magic happening where when they bring what they're coming with, and it might be knowledge about themselves and their situation, but it also might be what they have seen work for themselves and others. That's also where evolution can come, and come at a faster rate. So it's really helping them to see all of those adages where you can be right and you can be steady alone, or you can be transformative and rapidly moving together.
Wow. So your view of the primary care provider is, it's that, it's not a 9 to 5 job. It's not the work that they're doing when they come in. I mean, they have roles in the community as well too. And I feel like as we meet and speak with the students and the residents, are so focused on their 9 to 5. It's almost like they've lost sight of that traditional putting up your shingle. You're part of the community when you walk to go to the. I remember Dr. Dan mentioning about when he was in the grocery store and patients coming up to him. He's the celebrity doctor. Oh, this is my doctor, and they're happy of that. They're proud of that. So I feel that we need to help the students and the residents. Yes, of course, there's a 9 to 5, but it's the role that you're going to play in the community as a pillar in the community.
Yeah, I would add to that, it's also setting, because what I'm finding is more and more the primary care practitioner whose heart or eyes or vision or ambitions are set in the hospital. And that wasn't always the case. It used to be that part of what you knew with primary care is that you were going to be out in the community, either holding up your own shingles or working in community-based settings, group practices, even if they were private practices. And now what I find is if you're talking to a graduating class or a cohort, most of them want to be in the hospital, even in the primary care residency programs and tracks.
Yeah. Well, I mean, it's interesting. I spent the vast majority of my career at the University of Virginia, but I did spend 7 years working for ChenMed. And I've got to admit, when I remember during COVID, one of the local hospitals, I was able to get a COVID immunization through the hospital because, ChenMed would have given me one, but I didn't want to take it from our patients when I found out the hospital would give it to the doctors. And I went in the hospital. I'm like, you do a lot of your training, so it does sort of feel like home because it had probably been 3 or 4 years since I'd stepped foot in a hospital. Not that I understand the magic happens outside the hospital. Very, very little of the care of the population occurs in the hospital, but that is a great point. The other thing you were talking about, it sounds to me like we often say that it's not what's the matter with the patient, but it's what matters to the patient. And you're talking about it's what matters to the doctor too, right? Or the APP, what matters to the provider who's taking care of the patient.
Absolutely. Absolutely. It matters in their, not just what we were talking about at the beginning of that kind of mind shifts, but it really matters in motivation. It matters in satisfaction. I can't tell you how many diverse answers that I get when I start with, what is it that you want out of medicine? What do you think it's going to be like to be? What are you going to get from being a doctor? What is that going to be like for you? And there's an image that a lot of people come packed with that's still almost fantastical. And if you're chasing that, it just breathed in because and the reason I started asking it is I was seeing early career clinicians who clearly had fallen out of love with medicine. And so part of it is understanding now, and as a behaviorist, as you say, or a clinical psychologist, I also need to know what am I going to need to do to keep fueling that love fire? Because just like with any other kind of work, disillusionment can happen. Burnout, we know when we talk about pretty broadly burnout, but what we don't talk about is sometimes it's not the burnout. It wasn't burnout that took them out. It was literally falling out of love. And in any setting, love has to be stoked. It has to be poured into. It doesn't just sustain itself.
So in some ways, you're talking almost like a loss of identity as to what you go to medical school and you think it's going to be like this, and you come out. And so now, how do you incorporate that into doing the change management you need to do in your community health centers? Because obviously the community health, you got to keep the trains running as well as ministering to the doctors.
Yeah. I think it's really about reminding them of what community means, and that community is bringing in people at different stages from diverse backgrounds, diverse needs, which means within a community, depending on the topic, depending on the setting, there's going to be a different member who stands at the lead. And so if part of what I need out of medicine is to always be the one in authority, to always be the one with all the answers, to always be the one who's looked at with awe and revere and thanksgiving and all that good stuff, then it is going to be some disappointment, because part of getting to that change management is recognizing that depending on the change that you're trying to reach, you may not be the head or the driver for that change, or the appropriate person to be setting out the course for the change. There may be a piece of it that's yours to hold, and that you are the absolute authority leader, the one who owns that piece, and everybody needs to defer to that knowledge or that vision. But there will be other pieces in it where that person is not you. And it doesn't mean that that has to take anything away from you. It has to be viewed, and we have to start to shift their orientation so they see how it just magnifies, expands, grows, strengthens, and speeds up. And that's the biggest thing that I see. You can have the physician who is the leader, who has to be the one that figures it all out, who has to lay it all out, and then others just hold them accountable. And you may still get to the same spot, but you won't get there as fast as if you just really latch on to your part of the journey of that change cycle and join with everybody else to get it moving faster and farther.
Especially now that we're in the world, like you said, we're in the world of impact. It's not just what we prescribe or what we order refer. I mean, it's your ability to understand the person in front of you and then help influence them. Because I think about, even with ourselves, I'd like to think of myself as an incredibly influential person, but my wife and my children would tell you otherwise. I mean, even myself, there's days where if I'm not in the right headspace, I won't motivate myself to make better decisions or better choices. And so that I felt like in residency they did a great job with teaching us like what to do, like the doctoring piece. But then it came out into the world, the relationship between physical health and behavioral health being one and the same. Like, you cannot just address the physical health without understanding all the unmet psychosocial needs. And so how Yeah, I wanted to ask you, like, how can we start treating them one and the same? Like physical health and mental, this is the same.
Yeah. Well, when I meet somebody in the behavioral health room, I say, hello, my name is Dr. Sonya Bruton, and I'm the kind of doctor who deals with how you think, how you feel, and the problems that you have in your life. So if you think about that and recognize that if you're talking about mental health, what you're talking about is how someone thinks. That's not just their thoughts, the content of it, but that's their cognition, their ability to process, their level of understanding and IQ, their level of exposure, how you feel. Mood absolutely drives and has an impact on behavior, and the problems they're dealing with. There's no way you can look at those three categories and not see immediately that that has a bearing on your physical health, on your physical presentation, on your behaviors. But what I was going to say is, as you were talking, what was stimulated for me is there's another piece that's out there now, and that's this whole, I'm not going to call it competition, but I'm going to say collaboration and needing to figure out where in the community it fits. And that's AI as it relates to medicine. Because if I'm wearing both sides or talking from both of my hats, my clinical psychology hat, I'm in the clinical room right now that I come to every Thursday to see patients, but also my CEO hat, there's a recognition that we are already in the age of artificial intelligence in medicine, to the point that in my organization, I have just said, listen, it is how medicine is done these days. If you're not becoming facile, if you're not integrating it, you're out of step with medicine and where it's going, similar to where we were when we converted from paper charts to electronic health records. It is that pivotal to me. And so as I have been going to broader health conversations, so health evolution and summits where all segments are represented, payers, hospitals, academic institutions, community-based organizations, foundations, government officials, where AI or artificial intelligence lives in this space, and needing to be able to have your identity within there, to understand that we will not, as medicine continues to progress, have a human doing all stages. We will more and more have robotics and electronics in the mix as part of the care team, as part of the trajectory of a patient's journey in medicine. You've got to be grounded in who you are, what you bring, and how to do that in collaboration more and more. And if you can't, there won't be a place for you in medicine, I believe.
Right, because no longer is it who can memorize the most that's going to be the best doctor, because AI brings that forward in a big way. I agree with you. It's going to be interesting. It seems like a lot of people like to argue about the scope of practice for different professions, and we really need to be thinking about what the scope of practice for AI is going to be, and sort of how are we going to say we're not going to use it. It was a few weeks ago, I was at a conference on AI for the faculty at the University of Virginia, and they were talking about it in a big classroom, and so one of the professors in another department said we shouldn't allow our learners to use AI until they know how to do it the other way. And I was thinking, I'm not sure that's going to work. And the next day I walk into my office, there's a brand new third-year medical student, his very first clinical rotation, and he has open evidence open. And I'm thinking, yeah, that ship's already sailed. So
it's already sailed in medicine. The people that drive medicine, the people that determine what gets paid for, how it gets done. I've been in conversations recently where, I have been discounted even in conversations around workforce development and the shortage in the workforce. Doesn't matter. We have AI. We have, physician extenders is what they will be called. It's like, we'll have physicians, we'll have advanced practitioner, and we'll have physician extenders, and physician extenders will do all that. We won't need as many because we'll only need to do the people part. Everything else that can be done and will be done by AI and physician extender AI robots that actually do procedures, have conversations.
But you say only do the people part. It reminds me of a saying I once heard about leadership. It said leadership wouldn't be hard if it wasn't for the people. Oh, wait, that is the leader's job, is the people, right? So that is the provider's job, right? Is that interaction with the people.
You know, I'm telling you, I was blown away in how far things have gone. And what I was told and shown very clearly is the AI physician extender robots can do it all. The thing that's slowing down the placement, the interruption of business as we know it now, is that people aren't ready for the robotic physician extenders to do everything. And so they have gotten it down. So it used to be that automatically everybody would agree. The people part is that bedside manners, one would say in a hospital. In community-based medicine, that rapport with the patient, that joining with them so that they trust you and that they listen to you. And if you have to give sensitive news or scary news, anything that's laden with emotion, that emotional intelligence, anything that requires that as part of what you're doing, that surely has to remain in the people space. And what I saw and learned was, nope, they've got the ability to do that now. But what's keeping it at bay is that research shows all the people looking to introduce all these new ways of doing medicine is that humans don't want to receive it yet from someone that's not a fellow human. But I think what it shows is that in this world of primary care and medicine writ large, that what we've talked about here in terms of knowing your identity, having the motivators, being willing and able to join your knowledge with others, to accept what everyone or everything has to bring, will be critical, because there will come a day when these things will be part of what's done. And if you can't join with them and don't use them well and know how to integrate them into your practice, you just will be left behind.
I worry about underserved populations in general. I've stayed in this space, and you said it. Another thing that you said a couple of weeks ago when we were in DC last was that in our world, trust isn't automatic, and there's a lot of work we got to do to earn trust. And so I can see things being adopted wonderfully across probably most of the country, but with the populations who need it the most, the care coordination the most, I worry about what can be done. I mean, I guess to be an effective leader or an effective influencer, we'll have to use both. We're going to have to use both because we've seen it where just for having an MD behind your name, automatically the trust is at a zero. But then having a front desk person who's from the same community, who understands the patient, may have a 1 or 2 degree line of separation. Hey, now they're referring me. Hey, that I don't know about the doctors you've had before, but that one over there, I know this one. I can vouch for this one.
Right. We adopt that whole manage up philosophy because it is the most effective, where the people that are most like you, the people that you're going to see most consistently, the person that does a lot of your follow-up activities and efforts, that you need their endorsement. You need them to vouch for those up higher in the chain or further along in the chain for acceptance and adherence to really be in place. Absolutely.
How can we help teams that are moving so fast? This is a fast world. Like, you're moving fast, you've got all these things, community health, it's so much. I mean, there's just so much that's going on. Like, how can we help the teams stay grounded with the power of those intense interactions rather than getting caught up in the grind?
I think one of the things one of the primary ways you just hit on, and that's empowerment. And empowerment is not just giving people power, but it's also recognizing different levels of power. As the CEO of my organization, I am very clear and announce openly, I am not the most powerful person in the organization. I 100% am not. You talked about being from an academic institution in Virginia. I talk about all the time. when it comes to the closed door of an exam room, it is like a separate college or institution on a campus. That dean is the one who's in control and determine what happens or doesn't happen in that area of study. It's the same. When that door closes, the most powerful person in my organization is that clinician. At the front desk, the most powerful person in the organization is the patient representative who is getting them in and keeping our cycle time going, gathering all the information we need to get paid appropriately, making sure when they leave them and go to the medical assistant, when you talked about getting credit for your work and having data align with your outcomes, it's the medical assistant who's the most powerful person in the organization to make that happen, as well as our data analytics folks and the different forms they may have put in and the different algorithms they have pulling the reports. And so at every given turn, the person who holds your fate in their hands, and if we can agree that that really is the ultimate definition of power, that the most powerful person ever is the one who holds your fate in their hands. For me, that happens all over the organization every day. I have no illusions about that. I'm very clear about that. I treat people, I discuss people, and I pay people accordingly.
Wow. I hope that if anybody's listening, especially, it's very inspirational to hear you speaking in this way. I grew up in a small town. I was born in Big City, but grew up in Orfield, Pennsylvania, like a town of maybe 4,000 or 5,000 people. So we didn't have it was wonderful. It was a great place. At the time, I didn't think so, but now I'm trying to raise my children in that kind of an environment. But for people who say, there's such a huge gap in rural health in general. And so for many providers or meet people that, hey, I didn't grow up that way. You seem to love it because it reminds you of the way you grew up. But for people who didn't grow up in a rural, like having a rural childhood or even suburban, what's some words that you can advise them about the opportunities that exist in rural health?
It's interesting that you asked that question. I was just last week having, what could have been a hard conversation with a behavioral health practitioner in a very small health center in rural North Carolina who has been working there for about 5 years now and has not been able to fill their schedule. And, that's been bringing up a lot of things. Is it speaking to my ability? Is it speaking to do I have to worry about my value in the organization? Because at this rate, 5 years in, the person is not paying for their salary in the revenue or the work that they're doing with patients. To his credit, he does believe in the work and is committed to making the work accessible in this rural community that he's not from, but knows the difference that even having it makes. But having to, remind himself, buoy himself up. He doesn't have any colleagues in the organization. He's the only one. The whole organization is small. It's in a rural neighborhood. It's a rural county, so it's a small organization. They see 3,200 people total a year. And so I had to start there and say, when we look at how many people that you see a day, a month, a year, we can't equate that with your worth. Not your worth as a professional, not your worth as a practitioner, not your worth within the organization. Because even if we just boil it down to math, if the entire universe that you're pulling from is 3,200, and of that 3,200, 5% have the need for a behavioral health professional, have a need for it. Then we got to truncate down even further those that then would be willing to seek that help. Then you have to recognize that everybody isn't interested in pouring their heart out to just anybody. So this person is a male. And so there's some people for whom they wouldn't feel comfortable talking about what they think, how they feel, and the problems they have in their life with a man. Then you have to look at what's the age of that man. And the age of that man is late 40s, but in a community where more people die than get born. And so it's an aged and an aging community. And some of those folks actually don't want to talk to somebody in their 40s about how they think, they feel, and the problems in their life. And so when you keep doing those factors, you see that numbers may not be there, that in a rural community, like the number, if you're judging your worth and your value by volume, you may not find it. And there are other ways to bring value. For this particular practitioner and professional, he's a licensed clinical social worker. And so he was already offering and had already begun to do other things that the practice needed and the patients needed indirectly. He's doing a lot of population health management stuff that they need, talking and representing numbers and data to payers and insurers, making sure coverage covers the things that are being seen in the practice. When he's looking at the record to see who might have the need for a behaviorist or have an issue that needs a diagnosis or addressing, he's also seeing other things. And he's leveraging himself, the time that he is there, the willingness that he has to dig deeper. He's not digging deep into the life of a person right now. He's digging deep into populations and their needs at the practice. And he's doing that. And so I was able to help him see the value that that brings, and that everything isn't quantified by numbers. And, he has a lot of meetings where he introduces himself and introduces the service, and they say, I'm good, or thanks, but no thanks. And how to receive that message and understand that part of the work is also seed planting and making people aware and exposing. And it may not even bear fruit in his tenure, but it may still in that person's life. And so not needing to see or get gratification from the person real time. And so it's really shifting how we measure, shifting how we perceive, and shifting how we value things.
Wow. And you've thought this way since you completed all your training?
I come from these communities, so I get it. Like, I understand, I have seen the person with the greatest amount of education, training, and credentials behind themselves not be actually the smartest one in the room on the topic that's being discussed. I know that to be a possible because I've seen it. I've seen that if you get caught up in validation that doesn't fit your circumstance, all you're going to do is dilute your power and kill yourself. So I think life embedded this into me, survival embedded this into me. I shared with you all in DC that I had all of my care from community health centers, the federally qualified health center movement. But what I didn't share is, I come from very humble beginnings. My mother was an early teen mother. And so we were doing this thing called life together for a lot of it. And from that perspective, what I was able to see, what I was exposed to, I think taught me. I got to see a lot, and I learned a lot from it.
Oh my gosh, Dr. Bruton, thank you so much for taking the time. I know you're busy. I see you're in clinic right now. To have this conversation with us is very inspirational.
Thank you for having me. I enjoyed being with you all, meeting you, being right close to Dan and meeting you, Faisel, in DC, and I couldn't wait to have more time. So thank you for having me. I've enjoyed it immensely.
Oh, thank you so much.
What are your thoughts on relationships and community, the fabric of rural health? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.